just a few minutes for introducing the topics that we will cover today. And in particular, I would like to remember you the number of clinical conditions in which the renin and aldosterone measurement are useful, both for diagnostic and therapeutic purposes. And you can easily see how many of these conditions is a long list, and many of these conditions are extremely prevalent. Therefore, the measurement of and accurate enough to evaluate properly the system. We are using, since the old days, and you are all aware of that, the measurement of plasma renin activity. That is the enzymatic capacity of renin of generating in vitro angiotensin 1. However, this is a very complex method, and because of that, it has a large interlaboratory variability, which to some extent prevented a more extensive evaluation of the activity of the system. Nowadays, we have another way of measuring renin, which is not based on the enzymatic activity, but is a direct renin assay. That is, we measure directly renin mass. And that is based on two antibodies, one of which is the so-called capture antibodies, and the second antibody, which is called detection antibody, against the active form of renin. And by that, you can measure directly the concentration of renin in your sample. Campbell will go into details of all these subtleties about how to do this measurement. But I want to mention that we recently did a comparative study, collaborative studies in Europe, examining the capacity of the two methods to measure different ranges of renin, and as you can see in these slides, the coefficient of variation that we have got with the new direct renin assay is significantly and consistently lower than that found with plasma renin activity, again suggesting that these new methods have the advantage of being more reproducible among laboratories. Also, these systems are much faster, and they can provide you with the response within a relatively short time, within 1 hour for many samples. So these new systems are quite convenient from at least from a clinical point of view. The second issue, the second topic that will be covered by Jan Danser is about Pro-renin, which is a precursor of renin. We don't know yet exactly what is the biological meaning of this precursor. There are hypotheses about that and suggestions, and Jan will cover that topic. What is important to understand is this inactive precursor can become active for a number of reasons and under a number of conditions, and that may to some extent affect also the measurement of active renin, the one that I mentioned before. Also is important because we understand nowadays that there are renin and pro-renin receptors, and the occupancy of these receptors may have its own effect independently from the classical cascade that you see on your left, on the left side of this slide. Finally, I would like to mention the problem of aldosterone, because we are aware that nowadays that there are a number of our hypertensive patients who do have a form of hypertension called primary hyperaldosteronism, and for that the diagnosis, or at least the screening test, can be the calculation of the so-called aldosterone-renin ratio. That is the ratio between the concentration of aldosterone and that of renin in your plasma sample. And that, of course, can be calculated both with the classical plasma renin activity or the new direct renin assay. This slide is taken from a paper that we generated in cooperation with the group of Padua and Rossi and co-workers, where you can see how these ratio can be useful in the diagnosis of primary hyperaldo. But again, also for aldosterone, there are discrepancies among laboratories due to the different methods that we use. This is an example taken from a paper by Bildingmeier group, and you can see that depending on the method that you are using, whether or not there is extraction of plasma sample, you may get values of aldosterone extremely different. And again, then there is a need of having amelioration of our methods, and Michael Stowasser will cover that topic. So by that, I finish my short presentation.
Okay. Thank you, Alberto. Now, Alberto showed you a long list of conditions where one may be interested in renin measurements, but the focus of my talk is primarily that of primary aldosteronism, because I think this is a particular case where we need accurate, reliable measurement of both aldosterone and renin so that we can identify these patients and treat them appropriately. Can I have the first slide, or am I meant to? Oh, here we are. Good. Now, although in your program you may have seen that I'm comparing the discussing the plasma renin assay, activity assay in comparison with the direct renin assay, rather than use the term direct renin, I've chosen rather to refer to it as most clinicians would understand it. In clinical medicine, we often have assays. Well, we're often measuring samples or substances such as a tissue plasminogen activator, where we have the choice between activity assays and mass assays. And essentially, what's called a direct renin assay is actually an immunoassay of renin mass, or otherwise known as immunoreactive plasma renin concentration. And I'm comparing that with the standard old-fashioned assay, which is plasma renin activity. Now, the first question is, why do we measure renin? Well, the reason why we measure renin is because we want to know what the angiotensin II levels are, but we can't measure the angiotensin II levels because it's too difficult, and so we measure renin instead. Now, as far as nomenclature is concerned, when I talk about plasma renin activity, essentially what we're talking about is the measurement of angiotensin I production by plasma in an incubation, and this is dependent on the concentration of both the amount of active renin molecules in the plasma, but also the number of angiotensinogen molecules in the plasma. So it's the production of angiotensin I is the product of the renin and angiotensinogen in the sample. By contrast, when we're talking about the immunoreactive plasma renin concentration, we're just measuring the number of renin molecules in the sample, and this is independent of the angiotensinogen concentration. Now, when we think about excuse me, renin in plasma, we need to remember that under the umbrella of what we call total renin, there's a combination of both renin, which is active, and renin, which is inactive. It's the pro-renin, which is the precursor of active renin. And the relative proportion of pro-renin to active renin is about 10:1 in normal plasma. But this can vary depending on the clinical situation, so that in primary aldosteronism, it may be up to 50-fold higher pro-renin compared to active renin, whereas in situations of high renin secretion, the active renin may be 20 or 30% of the total amount of renin in the plasma sample. Now, the reason why we need to talk about pro-renin is because pro-renin itself, which has a pro sequence which can shown here, which can actually cover the active site and render the prorenin inactive because the angiotensinogen cannot get there. But a proportion of the prorenin opens up, about 1 to 2%, and this open prorenin is able to be enzymatically active. And it can also be recognized by the immunoassay we use for measuring plasma renin concentration. So in normal plasma, where you have about 10% or a ratio of 10 to 1 for prorenin to active renin, then the prorenin, because if you have about 2% intrinsic activity, it may contribute to 20% of the measured renin levels. And we need to be aware that the proportion of prorenin which is in the open conformation can be increased by dropping the temperature or dropping the pH. And so we need to be very careful how we handle the samples before they undergo assay. In primary aldosteronism, where the amount of prorenin may be 50 times higher than the amount of renin levels, then the prorenin may actually account for all of the renin that we're measuring in the sample, whether it be an activity assay or whether it be an immunoassay. And what this means is that the amount of renin that we measure in a sample with very low renin levels is very sensitive to inadvertent unfolding or activation of the prorenin if we don't handle the sample very carefully before it comes to assay. And as far as this unfolding of the pro segment of prorenin is concerned, we can have reversible activation, which may occur by lowering the temperature or the pH. And Jan Danser will talk about how we use a renin inhibitor to produce what may be an activation or an opening or an unfolding of the prorenin. And in addition, if we freeze and thaw our samples or treat them with acid, we can get an irreversible activation where a serine protease in the plasma cleaves off the pro sequence so that the prorenin becomes continually active. Now, this slide demonstrates the effect of temperature on the activity of recombinant prorenin. And here we have a sample here which has a very low activity at 37 degrees, but if it's cooled up to down to 0 degrees, shown in the white line, you can see that there's a much higher activity. And this increases with the amount of time the sample is at 0 degrees. But let's say after 48 hours, we take this sample and we bring it to room temperature over 3 hours, then the amount of measured renin activity, or if we were using an immunoassay, the amount of renin would halve. And if we incubated it for 1 hour at 37 degrees, then the prorenin would refold and the amount of active renin measured would return to essentially what we had before we started the experiment. And this is an example of a human plasma sample where it was initially treated at a low pH of 3 and at 0 degrees for 24 hours. And the amount of activity increased to about 70% of the total amount of renin in the sample. But when the pH was adjusted to 7.4 at 37 degrees, we had a rapid refolding of the prorenin so that it could so that the amount of active renin that we were measuring returned to what we had at the beginning. So that we have to think about all of these issues when we're talking about measuring renin in a patient in whom we suspect they may have primary aldosteronism. We need to consider what drugs they're on. And we need to correct electrolyte abnormalities. And if the patient is potassium deficient, then we need to correct that before we measure their aldosterone and renin levels. Now, Michael Stowasser will be talking about the measurement of aldosterone. And as far as renin is concerned, we need to take precautions. We need to know what time of day we're measuring the renin because it has a diurnal rhythm. We need to know the patient's posture. We need to know what sort of a diet they're on, whether it's high sodium or low sodium or whatever. We need to collect the blood, usually into heparinized tubes at room temperature, and centrifuge it very quickly, and then snap freeze the plasma. and before the assay thaw it rapidly to try and minimize the possible unfolding of the pro-renin, which may artifactually increase the amount of renin that we measure in the plasma sample. We need to consider what drugs the patient's taking, and we need to withdraw all the drugs that will interfere with the renin-angiotensin-aldosterone system. Now, for patients who are hypertensive, this can be quite difficult, but permitted antihypertensives include those shown here. We need to ask the patient whether they're eating licorice. As far as the measurement of plasma renin activity is concerned, what I've shown here is the standard Seeley method of the measurement of plasma renin activity. And essentially what happens is that she's using EDTA plasma, various peptidase inhibitors are added. They drop the pH to 6 to try and increase the rate of the reaction. And then they make duplicates of the sample. One duplicate is incubated for 3 hours at 37 degrees, and then the angiotensin 1 produced is measured. And if it's too high for the standard curve, then the sample is diluted before the assay is done. If it's too low, the key advantage of the plasma renin activity assay is that you can just incubate the plasma for a much longer period, say 18 hours, so that you can accurately measure very low levels of renin activity. And when these assays are applied, we find a close correlation between the plasma levels of angiotensin 2 and the plasma renin activity measured by this method. Now, we need to remember that the activity of the renin in the plasma is very much dependent on the angiotensinogen concentration of the plasma, and normal angiotensinogen concentrations are definitely in the first order range, so that if you double the amount of angiotensinogen, the same amount of renin will produce double the amount of angiotensin in the plasma renin activity assay. Now, normally what happens is that here shown here in the middle line, we have the relationship between the amount of renin in the plasma and the amount of angiotensin 2 produced. But if we have a sample with a high angiotensinogen concentration, then it immediately increases the amount of angiotensin produced, and what normally happens is that this causes a reciprocal inhibition of renin secretion, and the number of renin molecules in the plasma falls to return the rate of production of angiotensin to normal. And conversely, if we have a sample with a low angiotensinogen concentration, the amount of angiotensin production falls, and conversely, the number of renin molecules increases because you get a disinhibition of the tonic negative feedback of renin secretion, and the number of renin molecules increases to return angiotensin production to what it was before, or back to the normal range. So the advantages of the plasma renin activity assay are that you can measure low levels of plasma renin activity very easily and accurately simply by extending the incubation time. And if you incubate at 37 degrees, this allows the pro-renin to refold if it had inadvertently unfolded when the sample was being handled. The plasma renin activity assay represents the product of the concentrations of renin and angiotensinogen in the plasma. And it shows a good correlation with plasma angiotensin 2 levels, which is what we're really interested in if we want to understand the regulation of aldosterone. And so it provides a reliable measure of the stimulation of aldosterone production by angiotensin 2. But the problems are that it requires meticulous technique, and which is beyond some laboratories. A number of laboratories adopt modifications, so it's difficult to compare between laboratories. And we have problems of quality control, and we need standard plasmas and angiotensin 1 standards. Now, as far as the immunoassay is concerned, as described by Alberto, it's essentially using two different antibodies. One recognizes all renin molecules, shown here, and one recognizes specifically active renin or pro-renin with an unfolded pro-sequence. And it's important that this assay be done at 37 degrees to minimize any unfolding of the pro-renin during the assay. Now, when you look at a broad range of renin concentrations, you find a good correlation between the immunoassay and the plasma renin activity assay, but the correlation is not so good in the normal range, and particularly in the low normal range, which is what we're interested in if we want to identify patients with primary aldosteronism. There are a number of renin standards, which I won't go through. They're basically based on the Goldblatt unit, and which is the World Health Organization renin standard. And so that 1 micro international unit corresponds to about 0.6 picograms of pure active renin. And it's difficult to have to identify a direct relationship between the plasma renin activity assay and the immunoassay, but the production of a nanogram of angiotensin 1 per mil per hour approximates to about 5 nanograms per litre of immunoreactive renin. And now the reference ranges for the plasma renin activity assay, it's similar whether you do the assay at pH 6 or pH 7.4, and with a median of 1.4 and a range of about 0.8 to 2.2, but it is dependent on posture. And the sensitivity, though, is much, much lower than the lower limit of the normal range, and we can extend that by doing longer incubations. With the immunoassay, we have a range of about 7 to 76 microunits per milliliter, but the sensitivity is 2 microunits per mil, and we cannot manipulate the assay to make it lower than that. That's a functional sensitivity. And so the immunoassay is definitely less sensitive than the plasma renin activity assay when we're concerned about measuring low levels of renin and we want to diagnose patients with primary aldosteronism. Now, the immunoassay is definitely different from the plasma renin activity assay because it's the angiotensinogen levels themselves can actually change the number of renin molecules in the sample. And as I mentioned before, if the angiotensinogen levels are increased because of increased glucocorticoid secretion or estrogens, such as oral contraceptives or pregnancy, then the number of renin molecules fall. Or if you have low angiotensinogen levels because of glucocorticoid deficiency or high renin levels or liver disease, then the number of renin molecules may be actually increased, even though the plasma renin activity may be in the normal range. Now, the advantages of the immunoassay are that it's much less demanding of technician time and technique, it's more rapid, and it's easier to compare values measured between laboratories. But the disadvantage is that if the Pro-renin is unfolded because of the way the sample's been handled, if it's been at 4 degrees or if it's been at room temperature before the assay, then because the antibodies bind immediately, there's no possibility of the Pro-renin refolding before the assay. And so it may help to actually incubate the samples at 37 degrees for an hour to promote refolding before the sample sees the antibodies in the immunoassay. The immunoassay is less sensitive, and we cannot increase the sensitivity. And with low renin levels, there's a high interlaboratory variation. Now, some people may say, well, you see a similar low interlaboratory variation with the plasma renin activity assay, but that depends how long the samples have been incubated for. And it's true that if you have low renin levels and you just incubate the sample in the activity assay for 90 minutes, then you'll get you'll get a high coefficient of variation. But the coefficient of variation improves markedly if you incubate the plasma renin activity assay for much longer. So in conclusion, the immunoassay is more rapid than the plasma renin activity assay. It's more readily standardized, but it is definitely susceptible to unfolding of the Pro-renin, which may be a major problem if you're trying to measure very low levels of renin in the sample. And it has reduced precision at low renin levels because of that. And these are the levels we want to measure in primary aldosteronism. And particularly with regard to these low renin levels, there can be a poor correlation between plasma renin activity and between low and the renin levels because of the influence of the angiotensinogen levels, as I've previously discussed. And as I mentioned, it may help to incubate the plasma at 37 degrees before the immunoassay is performed, but most important from a clinical perspective is that you have to understand what therapies the patient's on and the clinical context if you want to be able to interpret the results of any assay. Thank you.
So we heard about the problems which may arise because we have particularly high pro-renin levels, and when there are conditions, let's say, such as primary aldosteronism, where renin levels are very low, well, it is possible that somehow pro-renin will interfere with the measurement. But there are other reasons why, in fact, one would be interested in pro-renin levels as such. For instance, under conditions where pro-renin levels in the body are increased, and this might be, for instance, in patients with diabetes who have the well-known microvascular complications of diabetes. And so the topic of this talk will be actually to see how, under such conditions, we could measure pro-renin, so not renin, but really pro-renin. And so I'll start by explaining to you how we might measure pro-renin, and secondly, maybe to illustrate some examples where this might be of interest. So just to start, and we heard it already a little bit in the previous two talks, of course, the body obviously generates renin, but as most enzymes, renin is not directly synthesized by the body. First, we have a so-called enzyme, and in this case it's called Prorenin. So this is not an exception. It happens by in the case of many enzymes. And so the kidney, in fact, first generates Prorenin, and here you can see how it looks, and you can appreciate, first of all, here the renin molecule, where we have an active site, and angiotensinogen is cleaved, and we get angiotensin 1. But here we have done the pro form, and then is the active site is actually covered by a so-called pro segment. It's 43 amino acids, and so this cannot display activity. Only when the pro segment is removed, and this happens in the kidney, then we get renin in the active form, and it can display activity. And we all know that the kidney, of course, stores renin, and it can be released if, let's say, the blood pressure is too low, or if there's exposure to a too low salt diet. So these are known stimuli of renin release, and this may happen acutely. But very surprisingly, and for reasons that are not entirely clear, although prorenin is not stored, it is being released by the kidney. And in fact, in very large amounts, and we've heard the term total renin already, and in fact, this is the sum of renin and prorenin. And remarkably, in blood, for instance, in humans, total renin for a very large part is actually prorenin. It can be up to 90, sometimes even 99% might in reality be prorenin. And the question, of course, is to some degree, why do we have such high levels of prorenin? And I'll get to that later. And we heard already the various assays by Dr. Campbell's talk to measure renin, the enzyme kinetic assay, of course, where we look at the activity of renin. Well, obviously, prorenin has little or no enzyme activity, so it cannot be measured in that way. And we heard about the immunoradiometric assays, where there's an antibody which recognizes the active site of renin, and it's depicted over here. Well, obviously, this antibody cannot recognize the active site in prorenin, because prorenin will have this so-called pro segment, and it's covering the active site. So, yeah, this assay cannot be performed, and nor, as I said, can we measure activity. But there is a trick to overcome this. Actually, what we can do, we can in vitro, let's say in a plasma sample, we can remove the pro segment ourselves by adding an enzyme. And usually this is trypsin. There are various candidates, but trypsin is a well-known one which has been used for many, many years in the last, well, decades, I could even say. And what then happens is actually that we add the trypsin to the sample, and we cut off the pro segment, and then suddenly what is left is, of course, renin. Again, because we have converted prorenin to renin. And now all the assays we have used before, we can apply again. We can apply, for instance, an enzyme kinetic assay. We can use the so-called the direct assay to measure renin immunoreactivity. And so what then actually we do in this case is we measure renin before this procedure, and we use that then to call total renin after this procedure. And so first we do the measurements under these conditions. And then we repeat it, and preferably in the same assay, after this procedure. And the difference then, of course, between total renin and renin will tell us exactly how much prorenin, in fact, is present in the body. So it's an indirect approach. We have renin measurements, we have total renin measurements, and we subtract the two, and this will tell us nicely how much prorenin we have. This has been used for many years, and it works very well, of course. But now we also have renin inhibitors as the latest type of blockers of the renin-angiotensin system, in addition to the ACE inhibitors and ARBs. And then some interesting observations were made, and also it became clear that sometimes there might be some problems with these assays, and I'll try to explain that. And in fact, you heard already a little bit about this. Here we again have the prorenin molecule with the prosegment, and you also heard that prorenin can display some activity, only a very small percentage, 1 or 2%. And in fact, what happens under these conditions, when it displays activity, what happens is that this prosegment is moving away. So apparently, the prosegment is not always covering the active site. There are conditions where it is moving away, and you see here the physiological conditions, pH 7.4, 37 degrees centigrade. Under those conditions, a minute amount of prorenin, 1 or 2%, has this so-called open conformation. But when pH is low, and certainly also when temperature is low, more and more prorenin may get into this so-called open conformation. But of course, that's rather some in vitro phenomenon probably, because these are the conditions under normal physiological conditions to which prorenin is exposed. So normally, a minute amount, 1 or 2%, has this so-called open conformation. And when it is open, we heard that already, it will display activity, and it can be recognized by the antibodies against the active site. And it causes then the problems we heard in Dr. Campbell's talk. But now back to the renin inhibitor. Because a renin inhibitor, well, obviously binds to the active site. And as soon as prorenin has this open conformation, a renin inhibitor will consider this more or less if it is renin, and so it will also rapidly bind to the active site, in this case of prorenin. It cannot do that here because now it's covered by the prosegment, but here it's accessible. And in fact, what then happens, because the renin inhibitor binds very tightly, all prorenin will stay in this so-called open conformation, and it will hardly go back. And so that's what will happen then when you incubate prorenin with a large amount or high levels of a renin inhibitor. Eventually, when you do this long enough, and under the right conditions and with high concentrations of renin inhibitor, the whole equilibrium will shift into this direction. So we start with the majority of prorenin in this closed conformation, but after exposing them to the renin inhibitor, eventually all of prorenin will be in this so-called open conformation. And you can see that on this slide. Here we have performed this approach, and in fact it's based on the original publications by Frans Derks, who discovered this phenomenon many years ago. And what you can actually see here is we use increasing concentrations of a renin inhibitor, in this case it's aldosterone, and then we start measuring prorenin in the renin assay. And so normally we can hardly detect anything, but then when we incubate it with the renin inhibitor, more and more prorenin can be detected because it has this open conformation, and eventually, and really using a high concentration of aldosterone in vitro, eventually all prorenin is in the open conformation, and we can detect it as if it's renin. So this implies then that now we have two ways of opening prorenin and measuring it in renin assay. The first is the assay which I explained to you, where we simply cut off the prosegment with trypsin, and then we really have left a renin molecule. That's pretty clear, of course. And the second approach now is by incubating prorenin ex vivo with a renin inhibitor at high levels, 10⁻⁴ you've seen, and then eventually it will all be in this open conformation. And the difference, of course, is that although the antibody recognizes this form and this form equally well, and so eventually we get exactly the same results, here the prosegment is still present, whereas here it's really cut off. But the results of this approach in both cases is exactly the same. Now, we have to then, I mentioned the problems which may arise during renin inhibition, because when we treat a patient with a renin inhibitor, what we see happening here, and I explained to you we can do that ex vivo in a plasma sample, may now already happen in vivo, in the patient itself. Of course, when a patient takes aldosterone, this drug will be in blood, and this can then also, perhaps to some degree, happen in blood plasma. And so what then happens is that aldosterone will bind to prorenin in blood. The prorenin will become into this open conformation. And in fact, when we then apply a renin assay, it will also already measure prorenin, as if it's renin. But in fact, it's still prorenin, of course. The prosegment is still there. And this is a problem. During renin inhibition, it means then that perhaps we might overestimate the renin levels because we will also start measuring prorenin. I will try to illustrate that on the basis of some actual samples we obtained in patient studies, which we performed together with Norman Hollenberg in the United States. What you can see here, and I'll try to guide you through it, and it's easily described in this paper which was published last year. But so what happens here is patients were exposed to either a renin inhibitor, aldosterone, and we measured renin after 5 hours, so very acutely, and after 2 weeks of treatment. And a similar approach was followed for the AT1 receptor blocker irbesartan. And then we also measured prorenin and using this indirect approach. So what you see here is that with aldosterone already acutely a rapid rise in renin, and somewhat surprisingly there is a decrease in prorenin within just a few hours. And then after 2 weeks renin rises even further, and prorenin tends to increase, but it's barely or not significant. For irbesartan it's different. No acute changes in renin or prorenin, and only after 2 weeks we see clear changes and rises in renin and also in prorenin. And now what has happened here actually, particularly to explain this rapid decrease in prorenin, and we should remember prorenin has a pretty long half-life of at least 8 hours, so a decrease within 5 hours is actually impossible. But what is happening here is actually the phenomenon I just described to you, prorenin being binding to the renin inhibitor, no longer recognized as prorenin, but then as if it's renin, so we get acute and high rises in renin, but in fact it is prorenin which is bound to the renin inhibitor, and then even after 2 weeks we have really massive rises in renin, much bigger than with irbesartan, for instance, the AT1 receptor blocker, and no significant rise in prorenin. But again, this is related to the fact that we underestimate prorenin and we overestimate renin. So how can we solve that? Because, yeah, it's all the consequence of this indirect approach. And, yeah, there is no way to correct for that. And luckily, a few years ago, a new assay has been introduced by a company in the United States. It's called Molecular Innovations. And this assay, in fact, is the first assay to really measure prorenin directly. So no longer this indirect approach where we have to make this calculation by subtracting renin from total renin. Now we can directly measure prorenin. And there's only one way of doing that, by having an antibody which recognizes something which prorenin only has, and which is actually the prosegment. And it recognizes the prosegment just at the place where it normally is cleaved off. So this approach will measure prorenin under all the various conditions, whether it's open or whether it has the renin inhibitor bound to it. Under all these conditions, the antibody can measure prorenin directly. And when we apply that to this set of samples which I showed you earlier, we see very nicely that now for aldosterone, after 5 hours, there is no decrease in prorenin, and after 2 weeks, there's a clear rise in prorenin, and in fact, it's exactly the same as we saw for irbesartan. So with this assay, we get the same results for irbesartan as the indirect assay, but the results are different versus the indirect assay when we now measure it in the aldosterone samples. We no longer have this in vitro problem, or actually in this case in vivo, the conversion of prorenin to the renin form. So I hope that I have explained the various ways of measuring prorenin indirectly, and since just a few years it's also possible to measure it directly. Now, why would we be interested, just the last couple of slides, to measure prorenin? What would be interesting in what clinical conditions, for instance? Well, first of all, I'd like to demonstrate here to you, and these are human data, after a nephrectomy, removing the kidneys, obviously renin is coming from the kidney, and so we have the red line here. Renin levels will go down to virtually 0 after about 2 days. So renin is gone, and so supporting that renin really in the body is kidney derived. But pro-renin, somewhat surprisingly, is decreasing, yes, but suddenly then it starts to level off again, and it does not go down to 0. So clearly then, pro-renin is not only derived from the kidney, but has other sources. And in fact, quite a few have been described in the human body. The adrenal glands, various organs of the reproductive system, the testes, the ovaries, the placenta, and also the eye. So there are various sites in the body outside the kidney, very surprisingly, which also release pro-renin. But for some reason, it's just pro-renin, and this pro-renin is not converted to renin. Such conversion only happens in the kidney. And so all these other sites do release pro-renin, but are unable apparently to convert it to renin, because otherwise we would have seen even renin levels after nephrectomy, and this is not the case. Now, a very famous observation I would like to quote here, which was made actually at the time just when pro-renin had initially been discovered. And this is a paper by Lütscher, which was published in the New England Journal of Medicine. When then pro-renin was discovered and people could measure it, what they did is, of course, look at pro-renin levels in various patient groups. And in this case, it were patients with diabetes. And a subdivision was made in the patients who had the well-known microvascular complications, nephropathy, retinopathy, and who did not have that. And here you see the numbers of years of diabetes. Here on the y-axis, we see the levels of inactive renin, or actually nowadays we call it pro-renin. And the triangles are the patients who do have these microvascular complications, and I hope you can see it. The little squares are the ones who do not have these complications. So all are diabetic patients, but the difference is with or without microvascular complications. And I very clearly see, you can see that the patients with the triangles, they all have much higher levels of pro-renin as compared to the ones who did not have these complications. And if anything, these levels start to increase further with the duration of diabetes. So it was proposed on the basis of these data that apparently pro-renin is a kind of marker of the microvascular complications of diabetes. And a whole range of studies has been able to confirm that in the last decades or so. And one interesting observation we were able to make in addition to that, thanks to a collaboration with a well-known diabetes research group, in this case in Denmark, Parving and colleagues, we made the observation together also, and actually the same as what Lütscher suggested, that in patients, diabetic patients who have nephropathy, we measured pro-renin levels, and we made a comparison to those who did not have nephropathy. And yes, we also saw that their pro-renin levels were elevated. But then, thanks to the fact that Parving and colleagues had samples stored in the fridge going back over a 10-year period, and even going back to the time before the onset of microalbuminuria, we were able to demonstrate that these pro-renin levels were already elevated over a whole range of years, and in fact in a very early stage, even years before the onset of microalbuminuria. So on the basis of these data, we could conclude that yes, this pro-renin is really a very early marker, and it may in fact predict the development of nephropathy. So on that basis, that's why I started the talk. It might be interesting to measure pro-renin under certain conditions, and this might be one of them. And to support its importance, I'm quoting you a set of data of a study, again, by Hollenberg's group. We should remember, perhaps, I didn't mention that, but diabetic patients then have very high pro-renin levels, as I showed to you, particularly when they have the microvascular complications. But when we look at the renin levels in diabetic patients, they are actually quite low, sometimes even lower than normal. And yet we all know that diabetic patients respond very well to blockers of the renin-angiotensin system. So they have low plasma renin, they have very high levels of pro-renin. And for instance, this is a slide showing you the response of diabetic patients to an AT1 receptor blocker, irbesartan. And what you're looking at here is the response in renal plasma flow, which will obviously increase when we block the system. So we have diabetic patients over here. And this is a control group of normal patients who did not have diabetes. And you can very clearly see here that the diabetic patients respond much more strongly to based on the same dose. Sometimes you get double the response. And so apparently then, despite these people having low renin levels, they have a much increased response to a RAAS blocker, irbesartan in this case. And so supporting perhaps that there is an increased activity of the system, in this case in particular at the level of the kidney, and that's exactly where these high pro-renin levels may occur. So supporting indirectly then that in the view of low plasma renin levels, there may be high tissue pro-renin levels and tissue angiotensin generating activity based on this pro-renin, and therefore this increased response to RAAS blockade in diabetic patients. So again, supporting a reason why one would be interested to measure pro-renin. Well, it's not only elevated in patients with nephropathy, which I dealt with so far, but interestingly, actually, when on top of nephropathy, the patient also has retinopathy, the pro-renin levels increase even further. And I try to make a subdivision here in the various forms of retinopathy, all in diabetic patients, no retinopathy, background retinopathy and proliferative retinopathy, and simultaneously a subdivision is made in the patients having no microalbuminuria and having microalbuminuria. So I told you already that having the microalbuminuria elevates pro-renin. You can see that here again in the various subgroups of retinopathy, but you can also appreciate that with the severity of retinopathy, also now pro-renin levels even increase even further. So in fact, very high pro-renin levels may be an indication of having the patient having not only nephropathy, but probably also proliferative retinopathy. And then why would this be interesting? I would just like to quote to you a famous trial which was published a few years ago, where diabetic patients were treated with an AT1 receptor blocker, candesartan, and where we saw that this drug had beneficial effects on the development of diabetic retinopathy. And perhaps this is based partly on the fact, at least related then to the fact that these patients have high pro-renin levels reflecting this retinopathy, and perhaps also supporting the efficacy of blockers of the renin-angiotensin system under such conditions. Conclusions then. Pro-renin is an early marker of the microvascular complications of diabetes, most likely because it contributes to local angiotensin production in tissues affected by these complications. For instance, I showed you the eye and the kidney. Well, there are two ways of measuring pro-renin: indirectly in the classic renin assays, but then we have to convert it to renin with trypsin, or we have to incubate it with aldosterone. Unfortunately then, the problem is that aldosterone treatment of patients may do similar things and even results in its conformational change of pro-renin in vivo. And then it will be recognized in a renin assay, and we get overestimation of renin and underestimation of pro-renin. We now luckily have a second type of assay, a so-called direct pro-renin assay, and this is based on the use of an antibody against the pro-segment. And I didn't mention this, but the direct assay is extremely rapid. You have results in only 2 hours, whereas the indirect approach takes several days. We have to convert pro-renin to renin with trypsin, or to incubate it with aldosterone for 2 days. So this is a very time-consuming and technically challenging procedure, whereas this new assay is in fact much easier. It is also, by the way, much more expensive, as you may appreciate. Finally then, one remaining issue which I would like to raise, and we've heard already in Dr. Campbell's talk about this also. Renin assays often, if not always, make use of a standard which is going back a long, long time ago, and you heard about the units which actually rely on a certain response in vivo of this renin, and it has this number attached to it. So the international reference preparation of human renin is usually used as a standard, and in fact this is originally a crude preparation of human kidney renin. Unfortunately, in pro-renin assays, which have only been very recently introduced, well, we cannot use, obviously, this renin as a standard because it's not pro-renin, so it will not be recognized in the assay. And these assays use now their own standards. And of course, these days we can generate recombinant human pro-renin or rat or other animals pro-renin. And in this case, recombinant human pro-renin is being used as a standard. It sounds very logical. But unfortunately, when we take the standard of this pro-renin assay, we convert it to renin, and we measure it in a renin assay together with this renin standard, they will not yield exactly the same result. And that's a problem, of course, if we want to compare the results of one assay, the Pro-renin assay, with the other assay where we measure renin. And it, in fact, then raises the issue that perhaps by now, and that's why I wanted to raise that here, we need a new world standard for renin and Pro-renin, let's say based on a pure sample, no longer on this crude preparation generated by recombinant techniques. And in fact, we have been working on that recently in close collaboration with the Swiss pharmaceutical company Actelion. And at this stage, together with them, and in fact the work was done at Actelion, we have generated a pool of large amounts of both pure renin and Pro-renin, which give the same result in the two assays. And it is freely available to anyone interested in these assays, and I've put my email address here in case you would be interested in working with this. That leaves me then at this end of the talk, and thank you very much.
Thanks very much, Alberto, and thank you to the organisers and IDS for this opportunity to speak today. So we know primary aldosteronism is now recognised to be a specifically treatable, a potentially curable form of hypertension. But the diagnosis of primary aldo is complex and time-consuming. Nevertheless, it's very important to get this right, as it involves selecting the right patients who may benefit from specific treatment, whether or not it be surgical or medical. This is the process that we use in Brisbane for the diagnosis of primary aldosteronism, including the screening part involving measuring the aldo-renin ratio, confirming the diagnosis involving a suppression test, and we use the fludrocortisone suppression test, determining which subtype of primary aldosteronism, be it the hybrid gene form or be it a unilateral or a bilateral form, which involves doing adrenal venous sampling. And the reason I'm showing this slide is that every step of this process involves accurate measurement of aldosterone. The immunoassays we have available for aldosterone have got limited comparability. Because of this, it's difficult to define cutoff values for primary aldosteronism, whether it's for screening, confirmation, or subtype differentiation. Each laboratory, therefore, has to establish their own reference interval. We now have heard about automated chemiluminescence immunoassay. When this slide was prepared, they'd been withdrawn from the market, but now we do have a new one being developed, which we'll hear about in the next talk. This is a comparison that was made by Scherpenbach's group some years ago now of 4 different immunoassays measuring samples from the same people. And you can see the marked differences in values in nanograms per litre amongst the different assays that we used. Furthermore, we end up with different reference ranges for patients depending on which assay is being used. There are alternatives to immunoassay, including liquid chromatography tandem mass spectrometry, which is a powerful analytical technique becoming used increasingly in the clinical setting. It gives the opportunity to provide more reliable measurements of aldosterone and cortisol in immunoassays than immunoassays. So this is a technique that we've developed in collaboration with the Waters Group. We have Don Cooper from the group here today who will take any technical questions as I'm a clinician. And the person who developed the assay as part of his PhD project is Paul Taylor, who couldn't be with us today. And the machine uses triple quadrupole instruments, so there are 3 different mass spectrometries going on. MS1 and MS2 are the filtering ones where we want to very accurately measure the analyte that we're interested in. And the cell in the middle is the fragmentation technique, so that the first fragment that we look at can be then fragmented further into 2 different fragments that we can measure very accurately with mass spec. So this is what we get with the first mass spec run, and you get this single signal here, which then goes through the fragmentation phase and is converted into 2 separate fragments that you see here and here, and it's this fragment here that we use to measure the aldosterone molecule. The importance of this system is that it's semi-automated, so all of the sample preparation and extraction for measurement of aldosterone is done online in this section here. As a result, we can get an aldosterone measurement within 8 minutes of entering the sample on the system. Here's a patient with Addison's disease. You would expect very low aldo levels here, and we don't see a signal at all. Here is the lower limit of detection, here at 70 picomoles per litre or 2.5 nanograms per decilitre in a patient. And as you can see, there's a very low signal-to-noise ratio. And this is a very relevant sort of clinical measurement in terms of use in clinical practice. This is the internal standard. This is a typical normotensive subject who had quite a low level at 5.2 nanograms per decilitre. You can see again the very low signal-to-noise ratio with this particular measurement. It has very good linearity for a fairly standard curve that is used with immunoassays from 2.5 up to 200 nanograms per decilitre. This is the inter-day accuracy and precision. So at these different concentrations, you see accuracy that's very high and imprecision that's very low. When we compared our measurement technique with external quality controls provided by the German Society for Clinical Chemistry and Laboratory Medicine, we were very happy to see this extremely tight correlation between our method and their gas chromatography method. When we used two different types of tube, either plain clot versus EDTA, it didn't really matter which tube you used. There was very tight correlation between the two. Most recently, Paul has begun looking at clinical validation of this method in patients with primary aldosteronism. And he did this by looking at LC mass spec versus immunoassay in two very important processes of the diagnostic workup. First, fludrocortisone suppression testing, and secondly, with adrenal venous sampling. And you'll remember the FST is used to provide positive confirmation of primary aldosteronism, whereas adrenal venous sampling is used to determine whether the primary aldo is unilateral or bilateral. So he looked at a total of 44 patients undergoing fludrocortisone suppression testing and 13 patients undergoing adrenal venous sampling. And in all these patients, the diagnosis that was arrived at clinically was obtained using immunoassay, which is our current clinical practice. With the fludrocortisone suppression test, this involves the collection of blood samples for aldosterone measurement at 7 o'clock after overnight recumbency, and again at 10 o'clock, that should be after 3 hours of upright posture, basally, and then again after 4 days of fludrocortisone and oral salt loading. And of course, we have to give potassium supplements to keep these patients normokalemic. This is our criteria for a positive test. If the day 4 upright, that's the 10 o'clock aldosterone, is over 165 picomoles per litre, that's about 6 nanograms per decilitre. But we have to satisfy a number of other criteria. Firstly, we need to know that cortisol is less at this upright stage than at the 7 o'clock recumbent period. And the reason for that is that if cortisol has gone up during this time, then we assume ACTH has gone up, and this could have driven up aldosterone and prevented aldosterone from suppressing. Secondly, we need to know that renin is suppressed, otherwise we can't hope to suppress aldosterone, even in patients without primary aldosteronism. And thirdly, we need to know that plasma potassium is normal, kept normal by potassium supplementations. So in other words, what we're trying to show is that aldosterone is autonomous of the renin-angiotensin system without any confounding influences of ACTH or potassium. Adrenal vein sampling, our successful cannulation criterion is an adrenal venous cortisol concentration at least 3 times peripheral venous. And our criterion for unilateral primary aldosteronism is that the adrenal venous aldo-cortisol ratio is at least 2 times greater than the peripheral venous aldo-cortisol ratio, and the contralateral ratio is no higher than peripheral, what we call contralateral suppression. So the affected side at least 2 times peripheral, and the unaffected side no higher than peripheral. We measured aldosterone and cortisol by our in-house developed tandem mass spec method. Paul has now validated cortisol as well as aldosterone. And here's an example of the day 4 upright aldosterone level. This is the critical one for establishing the diagnosis of primary aldosteronism following 4 days of fludrocortisone administration. You remember the cutoff was 165. Here is a clearly positive patient who has a level of 430. You can see here also that the cortisol level did not go up between 7 o'clock and 10 o'clock. Here is the 10 o'clock level of 255, the 7 o'clock level was 295. So we could exclude a rise in ACTH that may have prevented aldosterone suppression. The assay results obtained by immunoassay for 38 patients undergoing fludro suppression testing were positive in 36 of them and negative in 2 of them. However, tandem mass spec diagnosed primary aldosteronism in the same 36 patients, but also in the 2 patients who were negative by fludrocortisone suppression testing by immunoassay. The last 6 of the 44 patients were studied post-unilateral adrenalectomy after being found to have unilateral primary aldo confirmed by AVS. So this test was done to see if we had biochemically cured the primary aldosteronism, and indeed in all 6 patients there was normal suppression of immunoassay measured aldosterone during FST, confirming biochemical cure of primary aldo. And when we retested these samples with tandem mass spec, again we were able to confirm cure of primary aldosteronism in the same 6 patients, with the day 4 10 o'clock upright levels being less than the lower limit of detection, 70 picomoles per litre in each case. Coming to the AVS results, we saw identical lateralization results using immunoassay and tandem mass spec in 12 patients, of whom 8 were bilateral. I think that should be 4 were unilateral, I apologise. However, a 13th patient with non-lateralizing results by immunoassay, who was hypokalemic, had a large mass on CT scanning in the left adrenal, was clearly unilateral by tandem mass spec, and has recently undergone left adrenalectomy. So here was this patient. Here's the immunoassay results, aldocortisol and the aldocortisol ratio. On the right side, we've got good cortisol gradients, so we know we're in on both the right and the left sides. The aldocortisol ratio was lower than peripheral on the right, but it was also lower than peripheral on the left, which we found quite confusing until we reran the samples with tandem mass spec. Now you've got the ratio definitely lower than peripheral on the right, but definitely higher than peripheral on the left, which is consistent with left unilateral primary aldosteronism. And the difference, of course, predominantly was in this aldo sample here, which was over 250,000 picomoles per litre using tandem mass spec, but only about 8,000 picomoles per litre using immunoassay. Now, we don't really know why there was such a marked difference, and Paul Taylor has raised the possibility that this could have been at least partly due to some lab error of dilution correction. But he makes the point that unlike an immunoassay where all you get is a printout of figures, with HPLC tandem mass spec you actually see a signal on a graph, and so it makes it much, much less likely that you're going to make calculation errors like this. As you can see, for the analytical range of aldosterone, 70 to 1390 picomoles per litre, cortisol 70 to 1380 nanomoles per litre. So for some adrenal venous sampling results, you're going to need to dilute your samples to get them on the board. And here you can see an example of where a sample was diluted 10-fold and 100-fold, and there was very nice linearity between those measurements. So this is possibly the first reported study that confirms the clinical utility of aldo and cortisol results obtained by tandem mass spec for both fludrocortisone suppression testing and adrenal vein sampling. We believe that improved precision and specificity of tandem mass spec appears to enhance diagnostic accuracy for both procedures and has the potential to improve treatment decisions. The precise measurement of aldo and cortisol by tandem mass spec should become the gold standard for detection, confirmation, and subtype determination in primary aldo. But also, and I think this is very important for this particular workshop, this methodology can be used to assess the analytical capabilities of newly developed immunoassays, such as the ones we're about to hear from in the next speaker. Thank you.
Thanks, Professor Morganti. Yes, so today I'm going to present some data on the two fully automated chemiluminescence immunoassays for plasma aldosterone and plasma renin, and show you some preliminary data on the sodium load testing and the aldosterone-renin ratio using these new tests. So I won't give too much background because we already heard a lot from the previous speakers, but the purpose of making these two new assays is, and the background for that is that the introduction of the aldosterone to renin ratio as a screening test has showed that the prevalence of primary aldosteronism is increased greatly in a large percent of the hypertensive population. So following a positive screening test, the result needs to be confirmed by some kind of suppression test, such as the saline infusion test, which is used in Munich, in the university hospital there. So obviously, as we heard, accurate and reliable measurements for aldosterone and renin are very important, and method-specific, if not lab-specific, cutoff values are mandatory for the due to the substantial variability in assay results. So I'll show you a little bit about the methodology of the two assays and also the preliminary clinical data on the cutoff of the AIR in primary aldosteronism versus essential hypertensives, and also for the preliminary cutoff value for the saline infusion test in confirmed primary aldosteronism patients. So both assays are fully automated on the IDS-iSYS platform. Aldosterone and renin can be measured from the same EDTA plasma sample with a total volume of 500 microliters, and the combined throughput of the two assays is 76 tests per hour. So this is a description of the aldosterone assay. 200 microliter of plasma is incubated for 25 minutes with the biotinylated monoclonal antibody. After which time we have a second 5-minute incubation with an acridinium ester aldosterone conjugate tracer. So after this immune complex forms, it's incubated for another 10 minutes with the streptavidin-coated magnetic particles. After this stage, there's a wash step, and the triggers are added, at which stage the chemiluminescence signal which is produced will be inversely proportional to the amount of aldosterone originally present in the sample, as it's a competitive immunoassay. The linear range of the assay is 3.7 to 132 nanograms per deciliter, and it showed good precision, inter- and intra-assay precision in the lab in Munich, tested at these concentrations at below 13%. I also wanted to show you briefly that we checked a lot of the potentially cross-reacting steroids, naturally occurring and synthetic steroids, as this is obviously a very important point for aldosterone measurements. The highest cross-reactivity was seen in 18-hydroxycorticosterone with this antibody, as might be expected since it's the precursor steroid in the synthesis of aldosterone. And there's also 3% cross-reactivity with the urinary metabolite, the 3-alpha-5-beta tetrahydroaldosterone. And this data is in accordance to the data which is already being published for this monoclonal antibody, which was produced by Professor Gomez Sanchez many years ago in the 80s. So for the clinical validation of this assay to existing commonly used methods, we've done correlation against the Siemens code count radioimmunoassay. These are also results from the lab in Munich in 275 samples. There was a good correlation with some increased cluster at the low end. We also looked at the diazorin, aldoCTK, another radioimmunoassay, and this was done with a collaboration in a lab in Italy. So 100 samples measured there with fairly good R-squared. And finally, we correlated to the LCMS method from the Reference Institute for Bioanalytics in Bonn to the IDS-iSYS, and we were quite pleased also with this good correlation, even down to the low end of 5 nanograms per deciliter. So moving on to the direct renin assay. This requires 190 microliters of EDTA plasma, which is incubated in one step with the acridinium conjugated monoclonal antibody, which is the detection antibody, and 50 microliters of the biotinylated monoclonal capture antibody. So after this complex is formed, again, it's incubated with these streptavidin-coated magnetic particles for a further 10 minutes. Then there's a wash cycle, and after addition of triggers, chemiluminescence signal again, this time proportionate to the amount of renin present in the sample. And the sensitivity in linear range, as you can see here, is 1.8 to 550 microunits per ml. And there was good inter- and intra-assay precision in this range, as indicated here, again, when it was tested externally in the lab in Munich. So again, for renin, we correlated to many commonly used methods, such as this on the left is the Danser automated platform, the Danser liaison direct assay. So I plotted on the log scale so that you can see there's a fairly good correlation, even at the low end here, in 137 samples. There's excellent correlation to the CysBio renin immunoradiometric assay, which is to be expected. In fact, the antibodies used in this assay are the same as what are used on the ISYS assay as well. And finally, in Munich, they were able to do a correlation to a limited number of samples, obviously, because the sample volume is very high, which is needed to carry out both of plasma renin activity and to put it on the ISYS. So we're quite pleased. The correlation is quite good to plasma renin activity from the Diagnostic assay. So for the clinical validation, as I said, I wanted to show you the distribution of levels of aldosterone and renin in primary aldosteronism in essential hypertensives and healthy subjects, and talk about the ARR cutoff using the two assays. The primary aldosteronism cohort that was used was a selection of samples from the German CON registry, which were defined with an ARR cutoff greater than 1.2, and this cutoff at 1.2 is in nanograms per deciliter for aldosterone, microunits per ml for renin, with the liaison and the Siemens respectively. So it's important to realize that this 1.2 is a ratio which can only be used if you're using aldosterone in nanograms per deciliter and renin in microunits per ml. So it cannot be transferred for aldosterone in moles or for renin in grams per liter and so on. So it's very specific to these units. So this cutoff is a bit lower than what you would see in the Endocrine Society guidelines for these units, but it's actually the outcome of the retrospective study from these CON registry patients. So it's what is used for the combination of these two assays from the German CON registry samples. These primary aldosteronism patients were off beta blockers, mineralocorticoid receptor antagonists, and hypokalemia was corrected before measurement of the ARR. In 90% of the cases, we also excluded diuretics. And primary aldosteronism was defined by a post-saline aldosterone level greater than 5 nanograms per deciliter. So subsequent to the ARR and saline load, adrenal vein sampling and CT scan were carried out to confirm or exclude lateralization. And in the end, we had approximately 50% of each aldosterone-producing adenomas and bilateral hyperplasia in this primary aldosteronism group. The essential hypertensives that I'm going to show you were defined by 3 independent blood pressure measurements. For a lot of them, we also had 24-hour blood pressure, as they were patients who were suspected of primary aldosteronism and hence were admitted to the hospital, so they had 24-hour blood pressure. And other causes for hypertension were excluded as much as possible according to a standardized procedure of the hospital. So here in this scatter graph, I wanted to show you levels for aldosterone and for renin using the ISYS assays, which is in red, in the 3 groups: primary aldosteronism, hypertensives, and controls, so for aldo and for renin. And these samples were measured in parallel with the 2 methods, so for the Siemens assay and the ISYS, and the liaison and the ISYS for renin. So they were measured in parallel, and the point of this graph is to show that we are that we are having equivalence to the currently used methods. So you might be surprised to see that some aldosterone levels in primary aldosteronism, for example, are a bit lower than what you might expect, or that some renin are a bit higher than you would expect for primary aldosteronism, but these were not samples that were necessarily used to calculate the ratio for these patients. They were for many random samples from the patients while they were admitted in the clinic. And so it's not to show that aldosterone or renin by themselves can either be used as a discriminatory method to discriminate between the subgroups or something. So there's quite a lot of overlap, for example, in aldosterone for hypertensives and control subjects, as you might expect, but the discrimination from primary aldosteronism is quite good. So following to the ARR measurement, as I said, in Munich they are doing the saline infusion test, and to exclude any kind of essential hypertensive patients which might have had an increased ratio due to a slightly elevated aldosterone for whatever reason, or a slightly suppressed renin for whatever reason. So here I want to show you on the left two panels are primary aldosteronism patients, and on the right two panels, non-primary aldosteronism confirmed to be negative post-saline load. And here 5 nanogram per deciliter is the cutoff which is used in Munich to decide suppression or not. So this is the data pre and post saline load, and once again we want to show that the ISYS assay is equivalent to what is currently used in Munich, which is the Siemens code count RIA. So strangely enough, there were 3 PA patients who did show a suppression post-load, but I think the physician in charge decided to continue with the diagnosis, so these were later confirmed primary aldosteronism by a CT scan and surgery after AVS. So since all of the non-PA patients were also suppressed below 5, I think the preliminary cutoff which can be used for the saline load using the ISYS test would also be 5, as what is now currently used. So finally, to show you the aldosterone-renin ratio cutoff, which could be used on the ISYS in order to find the most appropriate cutoff and do the ROC curve analysis. We used primary aldosteronism patients, which were defined and were definitely primary aldosteronism with a ratio above 1.2 as the patient subjects, and the control subject. The ROC curve analysis were essential hypertensives, and I'm also just showing the healthy subgroup here just as a reference. But in order to do the ROC curve calculation, we only used primary aldosteronism and essential hypertension. So currently at this cutoff of 1.2, which I show here, which is what is used in Munich with the Siemens and liaison renin, we get a sensitivity and specificity for this test at about 97 and 87%. So in order to get the same sensitivity with the ISYS, we would have to use a ratio very similar to that currently used, but a little bit lower at 1.1. And I apologize, here it should be microunits per ml, so here's the ratio on the side. Yeah, and in summary, just to say that there was good correlation of both assays to existing methods as validated in external sites as well as in the UK at IDS. The precision was rather moderate in the lower concentrations as might be expected. There was, however, a good precision overall and acceptable sensitivity at the low end. The preliminary data shown here suggests that a similar cutoff for the aldo-renin ratio to that currently used at 1.1 should be used with the ISYS. Again, using these units, nanogram per deciliter for aldo and microunits per ml for renin, with a similar sensitivity and specificity compared to the currently used methods. And also a similar cutoff for aldosterone following the saline infusion test at 5 nanograms per deciliter should be used. And we'd like to do further studies to confirm the current data set with increased numbers of primary aldosteronism and hypertensive patients on controlled medication to support this data. And we hope that the availability of the fully automated aldosterone and direct renin will significantly aid in the diagnosis of primary aldosteronism. So just to thank the various groups at IDS in the UK and at the University of Munich, the professors who helped to collect the samples, and in Berlin and Italy in Vicenza. Thanks for listening.
Okay, 5 minutes are left for discussion. So whatever question, doubts you may have after this presentation, they are welcome. Please. Come to the podium so people can listen to you better. Please come.
Thank you.
For who?
Yeah, for the last speaker and also for Dr. Campbell. Yeah, in the last presentation, you mentioned that in your selection of patients, you excluded patients who are on beta blockers and also on mineralocorticoid receptor antagonists. And Dr. Campbell actually listed a longer list of drugs. So my question to you is, which is a very common one for clinicians, how important is it to, this issue of drugs, especially calcium blockers and ACE inhibitors, leaving the patients on that to do the test? And secondly, if you stop the drugs, how long would you actually have to stop the drugs, so that you don't get much interference from your plasma renin assay? Thank you.
Well, thank you. Perhaps I'd be happy to address that question. Well, as you probably know, we think it's very important that drugs have a major impact on the ratio. I was a bit surprised to see the cutoff that Jenny presented. It's less than half the cutoff that we use in Brisbane. And if we used a cutoff like that, we'd be swamped with patients with high ratios. I think that ACE inhibitors and angiotensin receptor blockers are very important. We once used to think they weren't. We used to think that because renin-angiotensin is already suppressed in primary aldo, blocking it isn't going to have much effect. But that has not turned out to be the case. And we see many patients now who have false negative ratios on an ACE inhibitor or angiotensin receptor blocker. You take them off it and up it comes. 10% of their patients were on diuretics, so that also could have brought up renin and lowered the ratio as the cutoff. How long you should take them off the drugs, we think for diuretics as much as 4 to 6 weeks. With other drugs, probably less, maybe 2 to 3 weeks. But even then, I've seen, for example, beta blockers cause false positives 3 or 4 weeks down the track. I don't know what the mechanism for that is, but we've seen it quite often.
Michael.
Calcium blockers, we think that the non-dihydropyridine, like verapamil, to a less extent diltiazem, has much minimal effect on renin and aldo, whereas when you start to get into the dihydropyridine group, then we and a number of other groups, including Mark Brown from Australia, have shown that renin goes up and aldo doesn't go up as much, so you get a lowering of the ratio. Again, probably 2-3 weeks off amlodipine is my suggestion.
Michael, can we say that after all, ACE inhibitors and ARBs are not that crucial? Because if they do something, actually, they are going to increase the specificity of this screening test, because they do increase renin, they lower aldosterone. So,
yep.
In all, the ratio should decrease, making the specificity of the test even better. So is there really point for a screening test to avoid also those drugs?
I think you're right. If the ratio turns out to be positive, then I don't think it matters. You've got a positive ratio in the face of a drug that may cause a false negative. I don't think specificity is the problem, it's sensitivity. That if you get a normal ratio in somebody on an ACE inhibitor or an ARB, I would repeat the ratio after stopping the ACE or ARB.
Other question, please. Come to the point. Oh, okay, microphone.
No, that's fine. Thank you. It's actually for you, Dr. Stowasser. Very nice presentation. I would like to know, are you measuring cortisol and aldosterone simultaneously in the liquid chromatographer? And if you are measuring any other steroids at the same time, or you're only interested in those two?
Yeah, we are measuring them simultaneously. And as yet, we haven't validated other steroids, but we're very keen to do so, including hybrid steroids, 18-oxo and 18-hydroxycortisol, which are important in differentiating subtypes of primary aldosteronism. And deoxycorticosterone would be very nice because you can look for other mineralocorticoid type forms of hypertension with that. So we're keen to pursue those sort of options too, but we haven't yet.
Jock, comment from your side?
No, I can't. I've got nothing further to add. Thank you.
Now for the first question, the question that was raised before.
In terms of the drugs, I reinforce everything that Michael says. I think that I think you have a contract with the patient that when you do the investigation, you need to do it under the ideal circumstances so that you can interpret the result. The patients don't appreciate it if you get a result and then you say, oh, sorry, we've got to repeat the test in a month's time after we stopped all your drugs because the result that you got the first time can't be interpreted. I think that patients like the proper answer correctly the first time.
Yeah, you know, one of the problems that clinicians encounter is that now they all have a home blood pressure monitor, and many of them have got resistant hypertension. And to keep them off all antihypertensive drugs for 4 to, up to 6 weeks, we find extremely difficult. And therefore, the question is, how do you actually bring it at a clinical level? Otherwise, I doubt whether my fellow clinicians are going to give them up for, that, duration of time.
Well, you can keep them on different drugs, calcium antagonists, alpha blockers, for instance. They are acceptable.
But you make a reasonable point that there are some patients for whom that is extremely difficult. Patients who may need to be on a beta blocker because they've previously suffered a heart attack, for example. And, there are certainly patients in our practice where we may say this is all too difficult and we will try an empiric trial of spironolactone based on the fact that the prevalence of primary aldo is even higher in the resistant hypertensive group. So I agree with you that there are many patients where it's impossible to change them all over to the non-interfering drug. So it's a fair point.
But a critical issue is that every patient started off on no medication, and that's when their hypertension was diagnosed. And that's when you should think about doing it. And so when I see patients who are referred, I say, make sure you get these tests done before medication is started. And I insist that, and I tell the patient to instruct their clinician, do these tests before you put me on tablets.
Other questions?
Sato from Sendai, Japan. So I'll ask a question about machine assays of aldosterone to a German lady. So how much minutes of total measuring time for aldosterone?
The total time is 43 minutes to first result. And it's the same for renin. So they have the total incubation time is the same for the sample with the antibodies. And then it's a few minutes extra for the wash step at the end. So it's.
Have you ever measured the aldosterone during adrenous venous sampling?
During the sampling, no, not yet, because the lab in Munich hasn't started yet with that.
Should be possible.
But yes, of course, and we're currently also working on a cortisol assay, a rapid cortisol assay, so that would be great in the future to do both tests.
Thank you.
Thanks.
Okay, I don't see any other hands raised. So I thank you all for being here this morning in this magnificent balcony or terrace, and I hope you enjoyed this presentation. At least I enjoyed all of them. I have found them very informative. So thank you very much again, and see you in the next occasion. Bye-bye.